Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of the Kidney Coach and co-founder of Kygenesis, a range of supplements designed for people diagnosed with chronic kidney disease. And I'm delighted to be joined again by becoming very fast one of my favorite guests, the beautiful Therese. Therese is a consultant pharmacist, health strategist, and wellness researcher who specializes in bridging the gap between traditional medicine and functional health strategies. She has a keen eye and knowledge on chronic diseases such as kidney disease, metabolic syndrome, high blood pressure, and she provides practical science-based solutions that empower individuals to take control of their health. So unlike conventional approaches that often focus solely on symptom management, Therese takes a deep dive analysing blood tests, identifying nutrient deficiencies, and assessing how medications, particularly diuretics, can impact kidney function. And her goal is to equip people with sustainable strategies that optimise health. She is also the host of her own podcast, The Enlightened Pharmacist, and I'll put a link to that below if you want to go and have a listen. Therese is amazing also when I spoke on your podcast of just how involved with her patients she becomes. She spends, I think you said like 45 minutes to an hour with them, and you get to do this one-on-one, really what feels like nourishing, deep work for a pharmacist, unlike how we might traditionally see pharmacy and the role that they play in people's health management. And it's not the role that you play. And I was really excited when we dug into that last time. I can't remember if it was on your podcast or on mine, to see what an active role you play and how important it is. And that's why I've got you back to talk about all things triple whammy when it comes to chronic kidney disease. So thank you for joining again.
It's a pleasure, always a pleasure. Fellow person that loves to learn, and your superpower is learning and growth and development, and that's what I love as well. And I think when I see patients and clients, what I love about it is it's real life stories. It just paints a picture and it helps you actually put all the science into application.
I totally agree. And actually, before we hit records, I can't remember if it was a patient or someone was like, oh, you're so knowledgeable. I'm like, when you podcast all day, every day with all these amazing people, I'm like, it's like I'm at school learning all the time. Like, and it's, you think you know something and then you talk to someone who's refined it and understands it even deeper and you're like, wow, I don't know. I need to go down the rabbit hole. But I love podcasting because for me, it's just learning 24/7. So yeah, it's great. So triple whammy, let's just dive into it because it is one of the biggest triggers for acute kidney injury, but people diagnosed with chronic kidney disease really need to be careful, especially if they, and so many of our patients are on these three. So let's walk through firstly what the triple whammy is, what drugs that involves, and go from there.
Sounds good. I'll just start with some statistics, like the Australian Institute of Health and Welfare in 2024. They look at how much people are using this triple whammy, and that's an ACE inhibitor, which we use for reducing blood pressure. Second one is a diuretic, and your pain medicines, your NSAIDs, or your non-steroidal anti-inflammatory drugs. They found that between 1.5 and 2.6% of people are on this combination. And we call it the triple whammy because one whammy is big enough because it's one of these medications. It can actually cause direct injury to the kidneys. And there's about 3 different mechanisms where something can actually injure our kidneys. So the first one is the physical injury. The second one is these drugs. They can create crystals, and then it obstructs like the kidney from working properly. And then the third one is actually increasing inflammation, releasing cytokines, as well as causing the whole activation of the immune and the danger signals, which causes more inflammation, the fire that actually we can't actually put out. So just to be clear, like each individual drug that we're going to be looking at, the blood pressure one, the diuretic, which helps remove fluid retention, and the pain medicine on its own, they can actually cause injury through one of these 3 mechanisms. So when we actually add them together, so one is one whammy, and 2 is a double whammy, and then 3 is the triple whammy. And we know that the more we actually stack up, like the higher the risk of problems.
It's really interesting. We'd written an article about it ages ago, but it still surprises me how many healthcare providers, and I don't know, you probably would see this in clinical time, but I often get older patients come to me that are on, I'm thinking of a really specific one I had with Parkinson's, who was on 27 different medications from about 5 or 6 healthcare providers. I've spoken to you about this one before, and it just did not check. They were on 3 or 4 different types of levodopa, and because the patient doesn't know to check. But had triple whammy. In fact, I would call it a quadruple whammy, because I think they had an ACE inhibitor and an ARB, 2 diuretics.
My goodness. Wow.
Yeah, and an NSAID. And so,
2
and of course,
diuretics. Goodness.
2 diuretics, and just had, again, different providers, an ARB and an ACE, and then NSAIDs, and has kidney, of course, issues because it's just not being checked. So would you say is it a lack of, and I'm not having to go at healthcare providers, but is it a lack of that healthcare providers knowing about the triple whammy, or is it when people see, maybe they see their general GP, then they might see a rheumatologist, and then on top of that, they might have a nephrologist, and which is, the case of my patient, and they're just not cross-checking medications. Is that what you think causes someone to end up on a triple whammy, or is it healthcare providers do need more education around this?
Oh my goodness, Fiona, you just opened this can of worms.
know,
all of the above. One of the reasons why I'm doing these medication reviews is because your right hand doesn't know what your left hand is doing. So GPs are the central primary caregiver, provider. However, they send patients to specialists, whether it's a nephrologist for the kidneys, endocrinologist for diabetes. So we get all these silos all working independently. And sometimes because the patient sees them individually and not in combination, the message gets lost. So a lot of times, the list of medications I get from the GPs are very different from when I see the patients and they said, oh, this specialist, they've started me on this, or they've dropped the dose on this. So that's A. And then the second thing is, trying to actually manage resistant hypertension is a problem. And most times you need 2, 3 combination agents. So it's not surprising that there is a need for an ACE inhibitor, which works to actually increase the relaxation of the vessels so that there's less pressure. And then you also use a different synergistic pathway, like with the diuretics, to remove excessive fluid, which causes pressure. So a diuretic like furosemide or hydrochlorothiazide. So they work in synergistic to actually reduce blood pressure. And then if that's still not getting them to 130, 80, if they've got chronic kidney disease, they might have to throw in another agent. So it's not common that you have an ACE inhibitor with a diuretic and then a beta blocker, plus minus a calcium channel blocker. So already you've set the scene for really, really low renal perfusion. And then if the patient has pain, and they go to the supermarket and it's available over the counter, and they might get a Nurofen, which contains ibuprofen, which is an NSAID, or they might go to the pharmacy and if they don't get checked, or nobody actually talks to them, and they purchase naproxen or something else that's only available in the pharmacy, you can see the writing in the wall that the triple whammy can easily feature, and the doctor might not be aware of it because they get these medications over the counter, so it's not in the system, so they can't actually run the necessary tests and precautions to ensure that they can lower the risk of kidney damage.
It makes it so obvious why someone like you is so important, especially, I would say, in chronic kidney disease, because kidneys are our filtering unit and they're detoxing. And if you've got any decline in kidney function, I would say even stage 1 chronic kidney disease, someone like you to review medications to make sure that they're optimal, they're working, and there aren't better options, seems like it should just be right at the top of the list of GPs to refer to. And of course, with the statistics around chronic kidney disease, that would, be quite a huge percentage of our older population. So, yeah, okay.
Yeah, Fiona, we covered in the last session where it's a silent disease like chronic kidney disease, and a lot of people they're going around not knowing they've got kidney disease because maybe they need 90% of kidney function lost before they experience the symptoms.
Yeah.
And in Australia itself, the stats are staggering. Like 1 in 10 Australians, and
Mhm.
1 in 5 First Nations adults,
Mm.
those aged over 18 years, are living with signs of chronic kidney disease and may not be aware of it. So I think it's important to get the kidney health check from their from your primary care physician, and it's a very straightforward test. You can get your blood pressure. You might do a urine test to find out whether they've
Yep.
got proteins in the urine, albumin, creatinine, and then you might do a blood test to find out their serum creatinine or any risk factors for diabetes or any of the other things that actually always come together with kidney disease. So it's a silent disease, and I think the key message is if they're at risk, they should really, or they're concerned, they should go and seek out like this test, which is really, really non-invasive and easy to do.
Totally agree with you. So let's walk through each of the drugs involved in the triple whammy. I'd love to understand from your point of view, because we've talked about it before in other podcasts, but we've never had a pharmacist walk us through the mechanism. And you gave me a sneak peek of a beautiful. So excited because I love PowerPoint. So the mechanism behind each of the drug and how that works, and how, and I don't know if you have spoken about this in the PowerPoint, but how they stack on top of each other to then, combine them, greater risk.
So when I was in pharmacy school, the thing that really helped me understand it was the visuals. So I'm just going to share my screen, and then you can see like what I've got here. So
perfect, I can see that.
Yes, perfect. So what we have here is the nephrons in the kidneys, and you've got, I'm going to make it a bit bigger. Okay.
Yes, perfect. Thank you.
All right, wonderful. So on the left-hand side is your normal nephrons, and you have the vasodilator bit, which is the inflow. So when you actually have circulation, that's where it enters into the kidneys, and then the vasoconstrictor bit is the outflow, if you like. And where the mechanism, or when the brown stuff hits the fan, is when you've got hypertension and you're trying to actually reduce it. Most times you actually work on, let's look at diagram A. You're actually reducing the perfusion, so it's low perfusion. So things like your ACE inhibitors is going to reduce the outflow, which is the vasoconstrictor bit, because ACE inhibitors, they actually vasodilate. So the inflow are your anti-inflammatories and your diuretics. It reduces the flow coming in. And then if you add sort of like your ACE inhibitors or your angiotensin receptor blockers, you actually have no outflow. And which means that if you got a pipe and then you switch on the tap, nothing's moving because the inflow is weak and the outflow is weak. And then you have a reduction in the flow through the kidneys.
Right.
Yeah, does that make sense? Yeah.
It does. And I had no idea that the angiotensins were working on the vasoconstricting, mechanism of flow versus the others working on vasodilation coming in. So that makes sense to me, that you basically got, like a valve that's not really pushing much pressure through, meaning you're not getting enough hyperperfusion and blood flow and waste products moving adequately through kidney tissue. Is that the layman's way of explaining it?
100%. So we'll go through the signs and symptoms in the next slide. But what you're highlighting is that because the kidney cannot do what it normally does in terms of detoxification, so there's toxins accumulation. And then the next slide will help people understand, like most times there's no symptoms. We call it, the patient is asymptomatic. So again, I think the key message is if you're actually concerned, it's very, very easy to walk up to your primary care practitioner and get a kidney health check. So when you have a build-up of fluid, because there's no outflow, you can get swelling in your extremities, which is your ankles, your hands, and your face. Sometimes you might have less urine to actually pass because there's no flow, just that pipe there's no input and there's no output. So it's just basically stuck and just not working. The color of the urine could be red or brownish. And then with all the metabolites that it accumulates, no wonder somebody might feel tired, be vomiting, And itchiness is one thing that comes out quite a bit. Like if they've got even, long-term kidney problems, so if somebody's itchy, there's a sign that there's a toxin buildup and accumulation of metabolites.
Yeah, which is a big one.
Yeah.
Perfect.
So I think it's trying to get increased awareness. Like, it's very easy to stack up the 3 medications, and even 1 or 2 on its own. If somebody has got risk factors, their kidney function is already reduced, and they're on more than 1 of these medications, they've got heart failure, they've got heart conditions, they've got diabetes. So things are already inflamed in the system, could actually even make the situation even more alarming. So it depends on the baseline of the person, whether it manifests as an emergency.
So the big question I guess people will be thinking is, I have got elevated blood pressure, which we know is one of the biggest contributors towards kidney disease, yet I might have arthritis and things like that. And so is there a medium ground? Like, is there a point where the triple whammy will outweigh because we've got treatment-resistant hypertension? Or in your point of view, are there other interventions, be it low sodium, which works definitely with people with certain genetics, dietary intervention, nutraceuticals that seem to be as effective or at least protective? Like, what can people do if they're thinking, well, I've got really high blood pressure and I know that's what's going to cause or is causing chronic kidney disease? How do I get around all of this stuff? What's the middle ground with all of this?
Yeah. So a trick I found is in terms of blood pressure, are we actually treating white coat hypertension or real-time blood pressure? So I think that's probably the first foundation piece that is probably the most important, that when they actually rock up to the GP, they might get higher than normal blood pressure in the practice, or if they see a naturopath or another practitioner compared to when they're at home. So I'm a big advocate that we do self-monitoring. And that gives you the most evidence in terms of accuracy, and it predicts like cardiovascular risk and heart disease risk. So I think I normally would get them to actually do their own blood pressure reading before food, before breakfast, before medicines, and then a 12-hour picture before dinner and before medicines. That gives us a 12-hour picture. Some people like to throw in a random one in the mid-afternoon, and that's fine as well. And I would give them a bit of a diary, and then they put the top number and then the bottom number. And then they might bring this to the GP. And I would tell them to actually bring their machine. Like, how long have they had their machine? If it's been quite a while, bring it to your doctor and compare it with the practice, because at the practice, by law, they have to actually calibrate their machines every couple of months. And that gives you a good ballpark of their sort of home blood pressure, which is sometimes more accurate than in the clinic. So that would help us ensure that the dosing of our antihypertensives, whether it's the ACE inhibitor or the diuretic, is fit for purpose, that it's not too high, because these changes are dose dependent. Okay, so that's the first thing I'll be looking at. And you mentioned so many things we can do, diet and lifestyle, to actually reduce blood pressure. So we know that stress regulation makes a big difference. So I've got clients who tell me, oh, I did my blood pressure, but it was so high the other day. And then I asked them, like, what's your stress levels? And he's like, it was over the roof. So it kind of matches like a lot of things. Even talking can increase blood pressure, coffee, food. And that's why we try to actually do it at the same time and the same conditions, so we can replicate it for a couple of days, and then we get the most accurate picture. There are machines where you can get 24-hour readings as well, and that's available through a lot of practices. So I think make sure that we're getting the right blood pressure reading, so we can actually titrate the drugs accordingly. And secondly, diet and lifestyle, stress, even exercise can actually help reduce blood pressure. I think that if you lose weight, you can drop 1 to 2 millimeters mercury as well. And then you mentioned salt. For some people who are salt sensitive through genetics, that might also make a big difference in terms of actually reducing your blood pressure and having a healthy diet. So I know in the chronic kidney handbook, they're saying avoid any processed foods, because apart from added salt, it's got lots of preservatives, so it takes more of a toll for the body to clear. So we want to actually reduce that bucket of inflammation. So those three things, I think it's a good starting point.
Yeah, I totally agree with you. There are so many basic things that we can do that may or may not affect blood pressure. So, okay, so someone comes to you and they're like, Therese, I've done all those things, like I'm not salt sensitive, I'm eating super well, I'm exercising, yet my blood pressure's still high, but I really want to prevent kidney disease. Are there other sort of then backup things that you're thinking about if people are really worried about, say, and I guess my other question is, do you sometimes let blood pressure go a slightly higher versus the risk of the triple whammy? Like, where is the nuance, and how does a patient know that their practitioner is working on the nuance versus what I generally find, which is primary care physicians generally will put blood pressure first over kidney function, because I guess the rhetoric is that kidneys, you can't reverse them, and that a heart attack or high blood pressure is more likely to kill you long-term kidneys. So I generally have patients that I've seen or spoken to where they're like, yes, my practitioner does know sort of about the triple whammy, but decided that blood pressure was more important. And even though my EGFR has dropped since putting in the diuretic and whatever, and we definitely know it's contributing to a decline in kidney function, they weren't prepared to reduce the drugs or have me find a happy medium of a slightly higher blood pressure versus. What is your take on all of that? Because that is a hard one to navigate, and for me to negotiate with a care practitioner.
Yeah. Yeah, so blood pressure is very important because it shows how stressed your vessels are. So sometimes there are other things that actually contribute to that, like your family history, your cholesterol. So we like to actually use the cardiovascular risk calculator, which puts together the age, the cholesterol, and everything else, and give you a number of what's your risk of developing heart disease in the next 5 years. And if it's more than 15%, you might be a bit more aggressive. So that's one way we actually look at the multifactorial components of risk for heart disease. So when it comes to whether you would aggressively treat like blood pressure versus manage pain, which is what you're saying, is because when you actually have the triple whammy, it's the pain thing that tips the balance. Apart from diuretics, there are like lesser, I suppose, ones that affect the inflow. Things like beta blockers or calcium channel blockers, which relax like the heart and reduces like the pressure, less impact on the flow, could be some alternatives to consider. I think it is about having a baseline number in terms of their creatinine, their serum creatinine, and then understanding an EGFR, because we know that the normal person, they lose about 0.4 every year, and that's normal. But when they go down to like a drop of EGFR by 4 points, in 10 years time, there's a higher risk of dialysis. So I think having the numbers handy and having regular monitoring of that will give us an understanding of the impact of the different antihypertensives. And then if we throw in like the NSAIDs, how's it going to impact your renal function? Is it going to drop your EGFR? And then if significant, your serum creatinine is more than 25%, seems to be the magic number, then it's danger, and then it might actually, stop the drug or reduce it according to the risk factor of the individual. So it's very much risk-based and on an individual level. And I think, what are the better, safer alternatives to pain medicines? And most times, like people with chronic kidney disease, they've got joint pain. So, that paracetamol can be a problem. It sucks up your antioxidants, your NAC, glutathione sort of like levels. So what else, are safer alternatives? And as naturopaths, I know, are really holistic. And I know you use magnesium, and there is evidence for magnesium in dysmenorrhea or period pain. And even in dental pain, like magnesium seems to do a treat. Even NAC can actually help in some cases as well. So I think it's like, what are better, safer alternatives? And I just did a whole podcast with Ananda Mahoney, and she's a naturopath that deals with the biopsychosocial, management of pain. And we know that how we feel affects our pain levels. And she's a big advocate of somatic psychotherapy, which is using the mind and body connection to help, like, yoga, different sort of practices to help relax and calm, a very, very overstressed nervous system. So I think it's about, what are the better, safer alternatives? What can we do for the individual? What are their risk factors? What else, are they struggling with? And how can we actually help them achieve their health goals?
Yeah, I love that. Obviously, always going to be an advocate for holistic interventions. And I guess, too, my other question to you, because I know you're so good at screening for nutritional deficiencies, is there, and you mentioned magnesium with pain, and I would say also magnesium with hypertension is a big one for vasodilation and things like that. But first off, are there minerals and nutrients that possibly the triple whammy will deplete the system of? Or is there, something that you see commonly in people on these medications, they might be low in certain vitamins and minerals, and then replacing those tends to make a big difference, that you don't need to use as high a dose or drugs at all?
Yeah. So we talked about dehydration the last time. And again, hydration is one of the most powerful strategies to prevent like kidney disease, because if you haven't got enough like fluid, it's going to increase the concentration of the drug in the body, which means that it's going to be more toxic and going to have more direct injury and cause more inflammation. So I think if I was a practitioner and somebody has got chronic kidney disease and trying to toss up between, do I aggressively treat their blood pressure or do I stop their pain medicines? I'll be doing baseline kidney function and looking at their electrolytes, like their sodium, their potassium, and seeing where they're at. And we know the bone as well can, be involved. Like osteoporosis is a big problem in our patients with chronic kidney disease, because, when there's inadequate minerals, we draw it from the bone. And that's when it becomes more friable and increase the risk of fractures. So it is about monitoring electrolytes, having, making sure that, we keep regular tabs on it every 3 to 6 months, and any changes that we make to the patient's treatment plan as well is a great way to actually understand how is it impacting their kidney health.
I love that. Okay, what else do you want to add or say, or that you think people need to know, and even healthcare providers listening, that need to understand when it comes to the triple whammy and chronic kidney disease?
So I think the three factors, like we mentioned, like hydration, because that's going to dilute the urine and reduce the risk of crystal formation. I think it's also about avoiding high doses. So anybody that has been on methotrexate, which is used for, rheumatoid arthritis for years, and as time goes by, your kidney function like changes. So you might be on the same dose, 10 milligrams once a week, like for 10 years. However, your kidney like function might have declined or changed. So it's important to actually get it reassessed and to use the lowest effective dose for as short time as possible. There are some cases where, the methotrexate that you can alkalize the urine with bicarbonate, and that seems to actually help reduce, because methotrexate can cause, crystals, and that can obstruct like the tubules in like the nephrons. And that's one way we can actually manage like methotrexate toxicity. The other thing as well, I think, is a healthy lifestyle. It's interesting that in kidney health, it's the only one area, apart from endocrinology, where they really specify in their guidelines that your diet, because if your kidney is kaput and you have metabolic acidosis, which means your kidney can't do its job of regulating homeostasis, the balance, or alkalinize the system. When you ingest like protein, that's going to increase acidity. So you need to help the kidneys to actually regulate and make it more neutralized and more alkaline. So I've heard people tell me, because in the past, a diet, alkaline or an acidic diet, I was wondering, how is that going to work? Because I thought the body is just going to neutralize, whatever we eat. But the fact to the matter is, when your kidney is declining, it cannot actually help, regulate the pH. You need to give it a bit of assistance. And currently in chronic kidney disease, they do give sodium bicarbonate, tablets to actually regulate that. However, with vegetables and fruits, can do the same thing. If we actually balance it. So interesting how health can be really simple, like cut out the processed foods, add in your fruits and vegetables. And I like to say at least, 2 cups of vegetables, like for 2 meals a day at the very minimum. And that's just going to help regulate like homeostasis and reduce that toxic acidic environment that can be quite inflammatory.
No, I totally agree. It's often, sometimes we overcomplicate things. It was, I was having this conversation with someone I was podcasting with this morning, and we had this, we said exactly that often there is, because I do so much biohacking, I'm like, there's no peptide that can outrun in kidney disease hydration and an alkaline diet. Like, I don't have a quick fix for that. So I've had a couple of my kidney disease patients that are doing our mastery course, and they're just like, my EGFR's dropped. And I'm like, what's changed? Oh, we added back in protein. We started to eat more acidic meals, or we were doing this. And I'm like, you just can't shortcut that. Unfortunately, the foundations will be what keeps you right. And then the little tweaks and things that we might try after are the things that we can try and buy back 1 or 2 or 3% EGFR. But you're going to make the big dent from stages 5 and upwards by really getting the foundations right, which is diet and lifestyle, stress management, sleep, all the things that you've spoken about. So there is no, you just can't get around those things. So it's such a good point that you've made. So are there any things that you want to reiterate to anyone listening about the triple whammy or healthcare providers that you think is really important, that other people are going back to their healthcare providers and saying, I'm on this triple whammy, I've got kidney disease, my EGFR's dropped, I'm concerned? What are some of the tips that people can take away and relay to their healthcare providers to make sure that this is taken seriously and really looked at?
I think if we actually can detect chronic kidney disease early, we can increase sort of like the preventative, there's a point of no return when you actually let the problem linger. And then the fire has already burned and damaged all the forest. You can't actually regrow it. So I think the most important thing is to get a kidney health check. Know your blood pressure, what the numbers are. Make sure that you know whether you do a P test, see whether you got any protein in your urine, which is the most common way to actually identify chronic kidney disease. And then get a blood test to figure out how high your serum creatinine is. Get a baseline on a regular basis, and if you got a family history of kidney conditions, things like kidney stones, you need to go and get it checked out because you're higher risk. And we know some things if you're a practitioner, like high doses of vitamin C, it can precipitate kidney stones. And then with kidney stones, like a low oxalate diet can make a big difference. So again, it comes back to actually being aware of what you have. So I think having the courage to actually get checked out makes a big difference. Like if you've got any pain around the area where the kidneys are, the back area, get it checked out. I think it's the key thing. And even vitamins and acids, which we use for reflux, like calcium can cause problems and people with kidney problems. But if you don't know you've got kidney problems, you continue like the whole damaging process, that fire keeps going on. So I think early prevention is crucial. Get it checked out, know your numbers, and then you'll be in a very good position to live a happy and healthy life.
I love that. And if people want to know more about you and, of course, your amazing podcast, I'll put the details in below. There's got a great podcast, Enlightened Pharmacist, which she has amazing conversations with a whole host of different people looking at different ways to marry, I guess, Western and more functional medicine and how we can bring them together, because they, like you said before, and with practitioners that come in that, even with our GPs and our specialists working in isolation, it's the same. We can all come together, then we can definitely, have better outcomes for our patients, which as healthcare providers, that's what we really, really want. So, Therese, thank you so much for coming back on and talking about the triple whammy. I'm thinking we should have you back to talk all things lithium. Big thing I see, and I've got a lot of patients, chronic long-term lithium use for bipolar.
Really?
And
wow.
It is.
Okay.
And I was talking to the guys in the US about this. I would say she was thinking it was about 5% of her patients, and I'm thinking of our mastery program, there's about 5 in there out of about 100 people. So yeah, it's about 5% and it's chronic kidney disease. You know, it's caused by long-term lithium use for bipolar. And again, just people not checking numbers, and it's not until they're symptomatic. And generally these patients are at about, I'm thinking of one at the moment, waiting for dialysis and transplant. They're sitting at 10% before it was pulled up. So yeah, so we'll have you back to chat about that. So thank you so much. For anyone wanting to know more about Therese, what she does, I'll put in all her links, her LinkedIn. She blogs on there and puts up great posts, and then her podcast link there as well. Thank you so much for being on the show. If you want to know more about what we do, head to www.kidneycoach.com. You'll find us on Facebook and Instagram under the same handles. And remember to hit subscribe and like. That way you'll get notified anytime we put up more content. And if you have any questions for Therese, put them down below and I'll be sure to pass them on to her. Thank you again for coming back on and sharing your wisdom and knowledge, and for being such an amazing pharmacist. I really appreciate you.
It's a pleasure.
All right. Thanks, everybody. Bye.